Hi, good afternoon, everyone. Thank you so much, Jen and Chams, and all of the partners who have invited us from Futures Without Violence Health Partners on IPV and exploitation to provide this in-service for you. It's a subject very near and dear to my heart. Basically, I'm a family doctor and I see these patients, and my work and involvement has come from seeing patients who've been trafficked and abused and in situations, unhealthy interpersonal relationship situations. And so with that, a little bit about Health Partners on IPV and exploitation. We are a national training and technical assistance partnership with HRSA's Bureau of Primary Healthcare, and we offer health center staff ongoing free educational programs and technical assistance as small group trainings, webinars and archives, clinical and patient tools, evaluation, and EHR smart tools. You can learn more at the link here. There is a lot of resources that we have available for you that you can adapt to your health center setting. Excuse me, I had a little cough. Our learning objectives today are to describe how you as a health center can operationalize care for people affected by intimate partner violence and exploitation, to list 3 ways your health center can provide comprehensive care and services for people at risk of or experiencing interpersonal violence or exploitation, and to identify some national resources and tools that can help you operationalize this work in your health center or in your organization. So really, we want to move this into practice, and it's not just about think tanking. So, but to level set, I know you've had 2 other webinars about this, so we're just going to level set, go through some definitions. What is intimate partner violence? It's when there's a person in a relationship using a pattern of methods and tactics to gain and maintain power and control over the other person. And it's not a legal definition, you know, it's not like we're saying there's a criminal justice involvement and this is going to be going to a criminal case. It's more about public health definitions and a broader range of controlling behaviors that impact your patient's health, including these things: emotional abuse, social isolation, stalking, intimidation, and threats. Just like intimate partner violence, the trafficking, there is a legal criminal definition of trafficking, and this is it. It's through the Victims of Trafficking and Violence Protection Act of 2000, and it has some very specific kinds of terminology and specific definitions, criminal legal definitions for labor trafficking and severe forms of sex trafficking. Now, while there is this criminal legal definition in healthcare, we're going broader. We're going broader because we're not criminal justice investigators. So labor trafficking is the recruitment, harboring, transportation, provision, or obtaining of a person for labor or services through the use of force, fraud, or coercion for the purposes of involuntary servitude, peonage, debt bondage, or slavery. And then severe forms of sex trafficking is the recruitment, harboring, transportation, provision, or obtaining of a person for a commercial sex act through force, fraud, or coercion, or a commercial sex act, and in which case the person is not yet 18 years old. So that second definition doesn't include force, fraud, or coercion. Now that's the criminal legal definition, but let's look at it from a healthcare perspective. And from our perspective, we're looking at it as a broad spectrum of experiences where we're seeing patients with these kinds of health harms, but we're not just necessarily making a criminal legal case for a person to be considered a victim of sex trafficking, or to be considered a victim of sexual exploitation, or to be considered a victim of sexual violence. We're looking at the health harms and the impact and the experiences of our patients. And so I want to really emphasize that point. It is not our jobs to be investigators, it's our jobs to take care of our patients. And I hope that sticks with you. If anything that sticks with you, take care of your patients, listen to them, listen to their health harms, listen to their symptomatology, listen to the impact that these experiences, whether they can be proven in a criminal court of justice or whether a prosecutor takes up their case, regardless of whether any of that happens, what is our patient experiencing? So you can see sex trafficking is in the middle, is in the most severe form of sexual violence, and then there's sexual exploitation, and then sexual violence more broadly. Same thing for labor trafficking, where labor trafficking is the innermost circle. It's a legal term, as you saw from the Victims of Violence and Trafficking Protection Act. And then labor violations is also a legal term. when employers violate federal, state, or municipal laws related to worker treatment, workplace safety, or record-keeping requirements. And then labor exploitation, which is what we are dealing with when we see patients who come in with different health conditions, from overuse injuries or sometimes workplace injuries. Labor exploitation, it's not a legal term. Not all forms of labor exploitation are illegal, but our patients may still experience health impacts from it. So I just want to make that clear. So the prevalence, it is something that we deal with more broadly in society. Between 1 in 2 and 2 in 5 people in the United States over their lifetimes experience intimate partner violence. For sexual violence, 1 to 3 and between 1 to 3, so that 66% to 25 to 66% experience sexual violence within their lifetime. This is a huge issue, and we're seeing it in our clinics. The health impacts are broad. I'm sure many of you who are in practice have seen this, and I'm not going to belabor the issue. This is not an exhaustive list. I usually put it into 3 kinds of buckets, where there's physical, mental health, and social harms. And you can see that some of those are listed here. Some specifics on the health harms for IPV and behavioral health. Anxiety, depression, PTSD, trauma, relationship issues, emotional detachment, suicidal ideation and behaviors. These are well known and well documented, but it's also well known and well documented that women may also be more likely than men to use prescription opioids to self-medicate for other problems from intimate partner violence. So there is these connections. When you have patients who are experiencing substance use issues, it would be helpful to dig a little further and find out what's going on in their lives, and they're experiencing some of this trauma and abuse in the past or currently. Substance use is another way for abusive partners to exert power and control. This is well documented. This is a study, over 3,000 people, to the callers to the National Domestic Violence Hotline, reported that they're pressured or forced to use alcohol and drugs by their partner. They're afraid to call the police because their substance use issues were they are afraid to call the police because of their substance use issues. 60% had partners who tried to prevent or discourage them from getting help and for their substance use issues. And they were also being threatened to report their drug use issues to someone in authority by their ex-partner or partner who is abusing them. So this is a way that people are controlled. So some of the dynamics, the power and control dynamics. Another specific thing we want you to be aware of is partner-inflicted brain injury and strangulation. These don't necessarily show up in our clinic in the acute phase, but they can have long-term effects. So more than 2/3 of intimate partner violence victims are strangled at least once, and the average is 5.3 times per victim. Same thing with brain injuries or head injuries, 40 to 91%. That's a huge percentage. And if you think about chronic traumatic encephalopathy in football players, and you think about the prevalence of intimate partner violence in our society, how many victims and survivors of intimate partner violence might be down the line at risk of CTE. So these are some the help screening tool here on the right-hand side of the screen. You can look that up. It's interesting. It gives you a lot of information about partner-inflicted brain injury. I don't use it in my clinical setting, but it does help you to understand some of the dynamics and some of the issues with partner-inflicted brain injuries. There's not always immediate physical signs. And victims can die from partner-inflicted brain injury hours or days after the assault. Think about subdural hematomas and things like that. Let's see, do I have a chat? Okay. So dental injuries, oral health resources, these are very important. I was just at the NAC conference in Chicago, and I was talking to one of the CEOs up in a health center in Washington, in rural Washington state. And she told me that her dentists are now doing a lot of the behavioral health screenings because of one patient case that they had where the patient could not lie down onto the examination table because she had just been abused and beaten and had back injuries. And that was their first case where really it mobilized their dentist to be involved in this topic. There's also oral health injuries, dental injuries, mandibular injuries. And so we do have some resources for you from Futures Without Violence on this. And we would encourage you with your dental clinics to think about incorporating this into your practice. All right, I have a short video. I think I'm going to stop sharing, and Jake from Futures Without Violence, Health Partners on IPV and Exploitation, is going to share it, giving you just a little bit of a glimpse into how it might present.
Flare-ups if we can. So I was looking at your record, and you've had 4 serious attacks that brought you into the ER in the past 6 months. So something is making your asthma worse. Any ideas what might be the trigger?
Well, you know, between these crazy attacks, I feel fine. I take the kids to school and I go to work. Nothing's really changed in that.
Well, let's just think about today. What are some possible triggers? Do you have a fever, cold, or cough?
Mm-mm.
Okay, allergies can also trigger asthma, hay fever and dust. Or smoke? Do you or your husband smoke?
I don't have any allergies and I don't smoke, but my husband smokes.
You probably already know this, but secondhand smoke is really bad for your asthma.
I know. He knows. I just try and avoid him when he's smoking.
You know, we have a really good smoking cessation program, and it's free.
No, no way, that's not happening.
Okay. In that case, is talking to him about where he smokes an option for you?
He, I, he's under a lot of stress and he overreacts. He lost his job. So it's just best to give him his space.
Mm-hmm. It can be really hard on everyone when someone in the family is stressed out. Now, you mentioned that he overreacts to everything. Can you tell me more about that?
I love my husband. I don't like him right now. He's really angry about losing his job. And it just makes everything worse. So I actually asked him to step outside with his smoking, and he blew smoke in my face. So I felt myself getting tighter, and I couldn't find my inhaler. So I went to go ask him, and he had it in his hand. And he said, "You get your puffer, and I get mine. Deal?"
I'm so sorry. That must have felt terrible. It makes me wonder if he's hurting you in other ways.
Oh, he hasn't hit me or threatened me. He just keeps my inhaler from me. He actually gave it to me before he walked out. But I knew it wasn't going to be enough, so I could feel. I could feel it. I had to call 911.
Well, you did the right thing. You called, you got help, they brought you here, and we were able to get your breathing under control. It sounds like a lot. I can see.
Okay, I think I'm back on sharing my screen. So that's an example of, that might not fit into a legal criminal justice example that would pass something. for the criminal justice definition of intimate partner violence. But you can see there's health impacts, there's power and control, and there's a lot of dynamics of abuse there. Okay, so now we're going to move into operationalizing care. And one of the things that we are doing now is really advocating for the use of universal education, a universal education approach to prevention and intervention. And we do this through cues, which I'll review, and safety card tools. We're shifting away from screening. And I know a lot of our requirements are to do screening, but if we do screening, we want to preface it with a universal education approach. And the reason is there's a lot of limitations to screening. No one is hurting you at home, right? And you're coming in with your partner sitting next to each other, and I'm asking you that question. Does the patient feel emboldened or empowered to answer that question honestly? Within the last year, has anyone hurt you or hit you, and I'm at my computer typing away, and my back is to the patient, right? Just depending on the physical setup of the exam rooms. Or, I'm really sorry I have to ask you these questions. We don't have enough time. It's a requirement of our clinic. You can just answer yes or no. And what does that mean? What does that signal? How important and how much of a priority is this for the patient? And so, there's a lot of barriers to somebody disclosing from screening questions. And so we think about it, there's low disclosure rates. It's not survivor-centered or trauma-centered. The resources are offered only based on a patient's disclosure. If you tell me, yes, somebody's hurting me, then I give you resources. But if you tell me no, but you're afraid, you feel embarrassed, your partner is threatening you, then you're going to say no, and I'm not going to give you any resources or any help. That's not workable here. And so it's a missed opportunity for prevention education. So we shift and we say, what if disclosure identification is not the goal, but the goal is really to help patients understand that there's help out there for the situation they're in, and when they are ready, that we are ready also to help them. So universal education, it eliminates gaps in our healthcare. It's a strategy to treat our patients with respect and be giving them information about healthy and unhealthy relationships. Sometimes patients don't realize this dynamic is going on. They think it's just normalized. And then where to get supports. So when you have screening requirements, like for example, prenatal clinics, prenatal patients every trimester, we have to do screening on IPV. We strongly recommend first doing universal education. So universal education, we use this cues framework. It's an evidence-based intervention, confidentiality, universal education, and support. And these are some examples. There are 4 different kinds of safety cards, which I'll quickly review for you. And you can get these materials from Futures Without Violence. And then you can also replicate them and adapt them to your health setting. So what is it? Confidentiality. This is an overview. We make sure that we let our patients know that we see them alone for part of every visit, and that we disclose when we must break our confidentiality. If they're going to hurt themselves, if they're going to hurt somebody else, we have to if they're a minor who's getting abused, those are when we have to break confidentiality. So we let them know up front that when we have to do that. Universal education, we're going to normalize this activity. It's something we do for all of our patients. We talk about healthy and unhealthy relationships. I give 2 of these cards because relationships change over time, and sometimes they have impacts on your health. You're here in a health center. You're here seeing a doctor, nurse practitioner, physician's assistant, nurse. And so we want to make sure that you're in the healthiest, we can optimize your health. And so also for you to have the information so you can help a friend or a family member if this is ever an issue for them. It's about health and safe relationships, ones that aren't, how they can affect you, how they can affect your body and your emotional state, and situations where people are made to do things they don't want to do, and tips to help you so you don't feel alone. And then we also have information where you can call and you can get more help if this is a situation for you where you are in an unhealthy relationship or if you have questions. So really, confidentiality, universal education, and support. Very simple. And then giving them the resources, those safety cards, or other information that you have in your health setting. Here's the evidence. The evidence, 15 years of analysis of the studies in maternal and adolescent health settings. This is what health professionals wanted. They wanted autonomy, empathy, and compassion. There are limitations to screening. We talked about those. The importance of confidentiality, and then universal education, and really getting that safety net support, cross-sector partnerships with domestic violence advocates, human trafficking advocates, civil legal partnerships, so that patients have the whole gamut of services that can help them if they are in this situation. So before implementing cues, we do recommend that your clinic, your health center, establish a policy that all patients are seen alone for a part of every visit. And we recommend putting signs up so that it's just policy, so that you don't get into a situation where somebody who's accompanying the patient is demanding and forcing themselves to be there, regardless of the situation. There is a video here. I'm not going to show it in the interest of time, but that you can use for training purposes at your health center. It shows how you could navigate some of those situations where a partner is demanding to be in the room. So support, importantly, disclosure of abuse or intimate partner violence or trafficking and exploitation. It's not the goal, but it does happen, right? It happens to our patients, and they tell us in our exam rooms. So we need to know how to support somebody who does disclose. So these are some of the supportive statements. Sometimes providers don't feel comfortable doing universal education or screening because they worry about how to respond. But these are what patients want you to say. I believe you. You don't deserve this. You're not alone. Thank you for telling me. Very simple things. Of course, you are then going to do your safety planning and connecting to resources. Oops. What happened there? And I don't even know what to say right now, but I'm so glad you told me. And so you're going to do all of the things that you do to get them connected. But I do want to just emphasize it doesn't take that long to do universal education with these safety cards. And I'll give you an example right here in this video. Hold on, I have to move it to 138. And these training videos are available for you and your health centers through Futures Without Violence, free of charge.
One of the things we started to do with all our patients is give them these safety cards. Even if they say their relationships are great, and
Oops, what happened?
even if they're not in a relationship.
Why?
Because we know that relationships change. And we also know that many women have friends and family who need help, but they don't know what to do. This card talks about what women do and do not deserve in relationships, and it has safety information and 24/7 hotlines on the back.
Thank you for these. My sister, she's been struggling a long time, and I keep wanting to figure out ways to better help her.
I'm sorry to hear that about her.
Yeah, me too.
Well, I'm glad these are useful to you and possibly to her. You can call the numbers on the back for more information about how to help.
Thank you.
We have.
Okay, so what do you think about that video? I don't know how to get this. Are you seeing these blue marks on the screen?
I do. I'm not sure how that happened. If you stop share and share again, it might.
Okay, let me do
I
it.
feel like that's how we've fixed that in the past.
Okay. Okay, so what do you think? Yes, it's gone. What do you think? Do you think that those safety cards, when she accepted them from the clinician, do you think they were for her or for her sister? I don't know if you folks can chime in verbally or
Yes,
on
you're
here.
welcome to come off mute. Okay, so in the chat, we've got some folks.
Yes,
say
so
her.
Nora says her, Suzanne says her based on her body language. Yeah, I mean, it's possible, but does it matter, right? That's the beauty of this. It could be for her. It could actually be for her sister. But does it matter? She's got the information. She hasn't disclosed. And now she knows that this provider is a willing participant in her journey, if it's for her, and also, you know, for her, if it's for her sister, that the healthcare system as a whole, writ large, is there to address and help in these kinds of situations. So that's what we're aiming for. So redefining success. Success is not necessarily a disclosure piece. It's measured by our efforts to reduce isolation and improve outcomes for safety and health over the long term, So growing strong partnerships with our domestic and sexual violence and human trafficking advocacy programs. So we have that safety net, the cues approach versus screening alone, the confidential environment, setting up that policy in your health center so that you see patients alone for part of every visit, offering patient supportive messages so that if they come to see me and then they move to Colorado and they see somebody else, they know that the health system and the health centers are there for them. Offer patient strategies to promote safety and health, and make warm supported referrals to the domestic sexual violence or human trafficking advocacy programs. Let's talk about comprehensive care. These programs that I've been mentioning, legal assistance and other resources. So the heart of the model that Futures has really been working on, and Health Partners on IPV and Exploitation has really been working on for decades, and for 40 years, I believe, is building these meaningful partnerships between healthcare and advocacy programs. Advocacy programs, they're oftentimes survivors themselves who help a patient or somebody who is experiencing violence or trafficking or exploitation interface with the different systems, right? This is a multi-system, this is a problem that is addressed by many systems. And so patients oftentimes needs help to navigate these. And so when we talk about meaningful partnerships, we mean the advocacy partner can help the health center and the health center can help the advocacy partner or organizations, and these kind of bi-directional referral systems. So you can, Futures has Health Partners on IPV and Exploitation has developed a sample template MOU that you can use a top to top level from organization to organization or program to program to create a partnership where, for example, the health partner, community health center partner might give health trainings or might have eligibility workers if you need to increase your patient numbers at the advocacy program or their shelters. And the advocacy partner can do in-services and trainings at your health center about their services and about how what the impacts of IPV and exploitation are. So it can be useful both ways. These programs work with survivors of violence, and they help to increase personal safety outside of the clinic walls. They do crisis safety planning, help with housing situations, legal advocacy for family court labor issues, sometimes also criminal justice issues, support groups and counseling so that patients and clients are really not alone. They have other people who have gone through this, children's services and employment support. So they're very helpful for the patients that we see in health centers. This is the National Domestic Violence Hotline. It's on, there's a text, text chat. There's also a phone hotline. And when you go to the website, there's a exit now, like if somebody, if a partner is coming, they can exit and it takes them out of this. So the partner doesn't know that they are looking for resources and help. The benefits, these are some of the benefits. I talked about some of them. You could help enroll some of those clients at the domestic sexual violence and human trafficking organizations into your health center. Oftentimes there are family support systems within there. our staff, our colleagues also, we're part of the general population. So we also have colleagues and sometimes personal experiences of IPV or exploitation in our community. And so this can help your staff as well. And it supports emergency preparedness and response. There are state and tribal coalitions, and there are DV Survivor Health Center enrollment tools here on the screen. I really encourage you to look at all of these resources because they can help your patients at your health centers. This is the sample MOU. Just to let you know that it is available. You can adapt it to however you're going to partner with the domestic sexual violence program. Okay, so I just wanted to ask this question out to you folks, and there's a small number on the call right now. So does your health center or your PCA have a partnership right now with a domestic or sexual violence advocacy program if you're a health center? Or if you're a PCO or a regional network, do you have a working partnership with your state domestic sexual violence coalition? Just getting sort of a pulse check.
Feel free to share verbally or in the chat. One says a Rose Andom, so in the Denver area.
Okay, perfect. Do you have a partnership, or do you just send them, like, do you work together on organizational level?
Yeah. Rosa has a response to that.
Okay.
No, they just give out the referral. Okay.
Yeah.
And then
So,
Deborah Woody also responds, we have our own advocacy program. Green River says that they work with Ouch, the state PCA, who I think is working with their domestic violence organizations.
I see. Okay, so a lot of different levels and stages of working with advocacy programs. We would encourage, it's good that those services are available on an individual level. We do encourage, organizational level partnerships, especially in this time when resources are getting smaller. And so, there's a lot of expertise within our partner CBOs. And so you can get some of those template MOUs here. So now I wanted to shift a little bit into the clinic workflows and supports. So protocols and EHR tools. So how many of you run the UDS reports for your health center? Are there people on here who do that? I see somebody chatted.
Green River is doing that.
Yes. Okay. Well, it is required. We have to, every health center has to report to the federal government, the uniform data system. And in 2020, the first time ever in Table 6A, health centers were required to report on two new metrics, which was human trafficking and intimate partner violence. So it's demographic information. And again, as some of you may know, the UDS is not patient level data, it's organization, health center system data. So we're not talking about individual patients here. We're talking about the health center as a whole. And what they are collecting is through the ICD-10 codes from when I see a patient in clinic. If I use one of these codes, they're collecting that information, the number of visits that were used in the year with one of these codes, and the number of unique individual patients with that code used, or these codes used. So, but it's not telling them who these patients are. It's just how many from the health center use these codes for visits and how many unique individual patients had these codes. This is really important. This is really important because if you don't measure a problem, you're not going to address it. So 2020 was the first year that it was released. So let's look at what we had. 2020, what happened in 2020? 2020 was sort of, you can see here, it's the high water mark for the number of patients for human trafficking, and also the number of visits for intimate partner violence and human trafficking. but it was also the year that the pandemic happened. And we shifted very rapidly into telemedicine or telehealth modalities, different modalities. The first year of measurement, we're going to consider that the high water mark because we didn't have these measurements before. And since then, it's been a challenge to really get back up to what we think is underreporting in the first place, but just to that baseline, because lots of folks don't know about these UDS measures. They also don't know that we have, in order to count our patients, we have to use specific codes. And they're also, clinicians like myself have often been afraid of putting this into the chart because of privacy, confidentiality, and safety reasons for our patients. So we'll talk about that in a little bit. So here's the 2024 UDS findings that were just released. Human trafficking, this is very small. And I think it's a very significant underreporting. And then intimate partner violence also. Think about it. We have 32.5 million patients that we see nationwide. And we only have 12,000 incidences of patients with IPV in that year. This is significant underreporting. We heard the prevalence issues for IPV earlier between 1 in 2 and 2 in 5 people within their lifetime experiences. So, we have a lot of work to do, because if we want to really help our patients get the help that they need, we need to make sure that we can demonstrate the breadth of the issue. Okay, so in order to help us in our clinical practice, measure the problem, get the UDS reports, accurate UDS reports, Futures Without Violence Health Partners on IPV and Exploitation has worked with 2 EHR systems, and we're going through them systematically. So OCHIN Epic and eClinicalWorks. And what we have developed with them are embedded cues scripts that are safe and confidential within the electronic health record, private. It links to the ICD-10 codes. It has scripts so that if your provider is not comfortable talking about this issue or doing universal education, it has the scripts and the prompts of what you can say. It has the confidential coding that doesn't go out on the billing sheets, ability to make the notes private, and links to the resources in case you're not sure or your health center does not yet have a partnership with a local, or maybe there's no local advocacy program in your area. Maybe you're in a rural area and you don't have one, but there are national links to the national hotline and the phone numbers. You can find out more from this link here on Health IT, Health Information Technology from Futures Without Violence Health Partners on IPV and Exploitation. And then I worked with them on OCHIN Epic because my health center is on OCHIN Epic. And we worked through some of the workflow challenges. We talked about how it drives practice changes and data collection and how we can improve. We are also in the process of doing the version 2.0 to update it on OCHIN Epic. And OCHIN also has a toolbox. If you are on this electronic health record, they have the OCHIN best practices and cues tools. It includes the scripts and the smart tools and a toolkit to support it. And then here's the information on eClinicalWorks that was launched in May 2025. It has some of the same features, but I haven't seen this one because I'm not on this health EHR. So would love to hear if any of you are on eClinicalWorks, and if you'd like to reach out to health partners on IPV and exploitation, we'd love to have your input and partnership on this. We also have released a protocol on IPV, human trafficking and exploitation, and a quality improvement tool. The protocol, I helped to write this. It is adaptable to your health system. It goes through workflows when a patient comes in, through the reception, to the medical assistant, to the rooming of the patient, the provider. The scripts are embedded in there, the ICD-10 codes. what to do and how to support your patient. So we have that. We're going to update it, but we do have the older version. And you can reach out to Health Partners on IPV and exploitation for this, and as well as the QA/QI tool to help improve your health center's operations. So there is evidence that the provider scripts work. So I gave you a lot of the scripts and a lot of the ways that we would say it and some of the suggestions. The provider scripts reduce reproductive coercion over time and increase the uptake of long-acting LARCs, long-acting reversible contraceptives, which can help patients who are being exploited, who are experiencing a lot of sexual violence and who may or may not want to become pregnant. And so these scripts are helpful, and that's why we're pretty clear that we wanted it embedded into the EHR. Let's talk about ourselves. Let's talk about our organizations and our health centers. You know, Futures Without Violence has a lot of different programs. One of them is Workplaces Respond to Domestic and Sexual Violence. We talked about earlier that that we are part of the general population as well. And our colleagues, you may know some of your colleagues who have experienced exploitation. And I know I have staff whose family members have been trafficked. And so this is an issue for us. It's not a us versus them, not us as providers versus patients, and we're just taking care of patients. This is about us. We're taking care of ourselves. So when you think about IPV and exploitation, we also want you to think about your system supports in your organizations to help yourselves and your colleagues. 68% of the healthcare workforce have experienced at least one episode of violence, abuse, neglect, compared to colleagues in other industries. We're more likely to experience workplace violence. Healthcare professionals, we also hear really hard stories, and so we can have secondary impacts from this, you know, moral injury, burnout, you know, hard things that we bring home, right? That we hear, that we experience secondarily through our patients and their stories. So we need to take care of ourselves as well. And it's not a bad thing. It's a life experience. If you are somebody who has experienced IPV or trafficking or exploitation, you know, this was a study that shows that staff who are also survivors report greater preparedness to intervene with survivor patients in a way that's consistent with best practices and ideal clinical care. So personal DV experience is not a barrier. It could be helpful to clinical care of survivor patients. I just want to emphasize that. This is the program at Futures Without Violence. It's called Workplaces Respond to Domestic and Sexual Violence. And you can, this is great. So when I started working with Health Partners on IPV and exploitation and Futures, I was looking through their website and I found this program. And I was like, wow, this is really, really exceptional. You can, if you're an employer, you're an HR person, you can click on this employer button. If it's a coworker, somebody that you're working with who's going through this, you know, we talk to each other. We're friends, we're colleagues, we're in community together. Somebody's experiencing this, you can try to help in this way. It's a great resource. And I encourage you and your HR departments and your clinical leadership to look at this, because this impacts you know, your coworkers, your colleagues. It does happen. Okay, so emergency preparedness and IPV. We're almost ready to take questions. I don't know if there's any, but so when there's a natural disaster or an emergency, rates of intimate partner violence and sexual violence and exploitation and trafficking increase. Think about it. The people who are most vulnerable are doubly vulnerable when they lose housing, when they're displaced, when there's a lot of disruptions in systems, social systems. And so these increased rates of intimate partner violence and sexual violence and exploitation that follow are well known. And so we encourage you, when you are doing your emergency preparedness planning at your health centers, that you incorporate these issues of violence into your planning. Know who the patient, what patients might be affected. Make sure you have information in the languages that your patients speak, so that they aren't left out when these dislocations do happen. And we do have some emergency preparedness briefs and resources for your health system to think about when you're doing your emergency preparedness planning. This is very important for health coverage enrollment. Usually there's open enrollment periods when you can enroll into the marketplace or different insurances. Being a survivor of domestic violence is considered a qualifying life event. That meaning, what that means is that you can use it as a qualifying life event to enroll in healthcare at any time throughout the year. Think about it. If a survivor leaves an abusive partner and they were attached to their health insurance, now this survivor no longer has health insurance. What are they going to do? Right? So it is available for that survivor to enroll in health insurance and be eligible at any time throughout the year for this qualifying life event. And so that's really important. Your eligibility staff should know that. And advocates know this at the advocacy program. So they can also help your health center in that way. And so I think I talked really fast because I was worried that I wasn't going to get through all the material, but I wanted to thank all of you who are here today. I know time is precious, especially when you're a frontline provider, as I am. And I really want to thank you for all that you do for your patients and your communities. And with that, I'll just open it up for questions. And should I stop sharing, or?
Actually, will you go to the next slide?
Oh, right. Sorry, I forgot.
Perfect. No, that's great. And then yes, folks, feel free to come off of mute if you'd like to ask a question of Dr. Chang directly, or you can put one in the chat. We are happy to read those out on your behalf. And we do have a couple minutes. So while folks are thinking of their fantastic questions, I will mention the community partnership. So next month on September 18th, we're going to be digging into that more directly. So we're going to be having Lisa Brockmeyer, who's the Behavioral Health Service Line Director from Elevated Community Health, and she's going to present on continuity of care, building partnerships with community-based organizations for IPV and human trafficking. So I highly encourage you all to come. We're going to have up all your resources that you guys shared with us today. And then we're also going to give you an opportunity to speak with your state primary care associations. So if there's any additional support that you all feel like you need in order to build those community partnerships, we'll take some time to address that as well. We want to make sure that we're continuing to focus on this even after the series concludes. Excellent. All right, about enough time. Jen Davis, it looks like you've got a question. Feel free to come off of mute and ask.
Hi, thank you so much for this. I learned a lot of new things today that I did not know, so thank you so much. My question is on one of your later points there about this is a qualifying event for insurance eligibility around open enrollment. What sort of proof needs to be supplied in order for the eligibility to be determined for them on enrollment?
You know, I am not sure on that, but I think there is no necessary proof. I think you just have to basically attest to it. We can get back to you on that. Jake from Health Partners on IPV and exploitation. We can get back to Jen, and then Jen can clarify through email to you folks.
We'll follow up on that, and we'll address it. Yeah, that's a great question to follow up again next month as well.
Great. Thank you so much.
Thank you, Jen. Appreciate your time.
Any other questions? Well, we've got Dr. Chang here. Special opportunity. Excellent. Suzanne, go for it.
You're getting PCA questions because we're like, this is so fascinating. Kimberly, since you talked a little bit about UDS reporting, we've looked at what we can see statewide, but it's hard to know what to do with that data. You know, like at a statewide, do you have a conversation with the QI peer group? Do you bring it up with medical directors? Do you, like, where does that conversation occur when you look at that data? Curious if you've seen others do that or best practices on how to have a conversation about it.
To have a, so I'm just gonna pull it. So so I would say, you know, these are table 6A, right? These are table 6A information. It's just demographics. It's just describing the problem. From my standpoint, so to me, when I look at these numbers, I think, oh my God, we're doing a terrible job. I think we're doing a terrible job of helping these patients. And I know that we're doing a terrible job because I see these patients in clinic. And I have seen, like, as for human trafficking, the reason why I got into this work with Futures Without Violence is because I was seeing a number in 2004. I was seeing like I had 20 teenage kids who were being trafficked in Oakland, right? That's just me. I'm one doc, right? And one teen clinic. So I know these are low numbers. And to me, I think it just means we have to redouble our efforts to train, to make sure that that clinicians are doing this, that they feel safe and comfortable doing this kind of, you know, making sure they do these codes. I mean, that's not the most important thing for me as a clinician. I think coding is, like, maybe I shouldn't say this out loud, but that's not my highest priority. My highest priority is really taking care of my patient. But I think when I see these numbers, it's undercount. I think we're missing people. I think when you have these undercounts, it means less resources for the domestic violence advocacy programs, for health resources, for integrated behavioral health, for oral health care, you know, for health centers in general. And so, you know, it's not as direct of an impact, but I would say when I look at the numbers, I feel sad. I don't know if that's helpful. I don't know. I mean, it's demographic data. It's not really telling you what to do with them. But for me, what it's telling me is that I need to keep working with Futures Without Violence and trying to, you know, go to PCAs and health centers and really try to really reinforce that this is an issue affecting our patients. I don't know if that's helpful. Probably not, but
I think it's helpful. Thank you. We have a question in the chat. Any further resources or education for ICD for providers? How do we make sure this stays confidential and patients' partners do not figure out how they got help?
So, you know, this thing with the charting is a really complicated issue. We have to do it. We have these codes. We want, you know, the higher up funders, federal government, to know that this is an issue. And so that's why we do the coding. And then there's the issue of we're balancing out, could it cause harm? And so that's why when we worked with OCHIN Epic and eClinicalWorks, we made sure that it didn't go out on after visit summaries. It didn't go out on problem lists. In the OCHIN Epic, I just did an in-service for health partners on IPV on the OCHIN Epic and how I use it in my clinic. And, you know, that's in a protected module, so it doesn't attach to any of these other things. Now, having said that, when we were back on paper and we wrote it, you know, we would write things in the chart all the time, or I would. And, you know, I think it's just with this, the portals and things, it doesn't come in there. You know, so we do our best to try to limit it through the EHRs. And that's why a few health partners and IPV and exploitation is really spending a lot of money to work with the EHRs so that it can be protected as much as possible.
Yeah. Thank you. I want to make sure we get this in on the recording because Tierney from the Montana Primary Care Association wrote in. Sorry, I tried to jump in on the question about qualifying life event eligibility since I lead a navigator enrollment team, but got kicked out of the meeting, so she's back now. To access a special enrollment period for survivors, the standard is self-attestation, but it's important to know that the process is different. This SEP is accessed through the helpline call center only and is not screened in the online application. It also impacts how the rest of eligibility questions are answered in that process. So it's helpful to have assistance for those folks. So if your health center's got O&E support, sounds like they're going to need support. And then she also shares this as an outdated presentation from CMS, but it does outline some of the health coverage eligibility processes for survivors. And I'm happy to expand on this if there are any other questions. Apologies if this was stated while I was briefly offline, but wanted to make sure it was noted. It was not shared while you were offline, so this is fantastic. Thank you so much.
Yeah, that's great. Attorney
Yeah.
Stewart, I wonder if Jake and Health Partners and IPV can touch back with you on that.
Fantastic.
Absolutely. And I hope you can hear me, but I will also be on the next meeting, and I believe I'm potentially the facilitator for my group of Montana PCA members next month. I can also share some more information if that's helpful.
Great.
Yeah.
Hey, Jake, I wonder if you can touch back on the eligibility question with Ms. Queen Stewart from
Yeah,
Montana.
sure.
Great.
I will put my email in the chat.
Thanks.
Fantastic. Excellent. Making connections. Love it. Deborah writes, our advocacy program uses a separate program that organizes the demographics from them to report back to the individual grants that we work with, including the state and OBC. This protects patients. Oh, I think this is referring to the UDS numbers, how one example of how they are able to utilize it. So fantastic. Excellent. Well, I want to be mindful of everybody's time. So I would love to say thank you to Dr. Chang for sharing your expertise with us today. This was really fantastic.